Hello and welcome back to SPT with JZ. This is episode 6. I'm Zach Carson.
I'm Josh Griffin.
And we are going into the 7th week of the program here at Grand Valley State. We are very excited because we have more exams and testing coming up. So just like we expected, hot and heavy throughout the remainder of probably the entire 3 years.
Yep, probably.
So this week was kind of a gap week. It was nice. Nobody was going crazy. It's just more or less a lot of studying. But we didn't have any exams. We didn't have any practicals. It was kind of nice. We were just going to class, trying to learn the information that we could, and then setting aside the time for studying. But next week we do have, you guys got the anatomy exam coming up. We have practicals for our foundations class in which we have to do range of motion testing and this, that, and the other. We'll talk about that a little bit when we break it down. Then we also have a quiz and evidence-based practice. So, according to the syllabus, we do. But we'll see, since we got kicked out of our classroom last week.
Yeah.
But yeah, I think that's pretty much it for going forward. What we have this week is pretty heavy. A nice plate full of spaghetti. But we're going to break it down this past week, kind of talk about the things that we learned, and Josh is going to lead us off with anatomy.
All right, so this week we looked we're in the head, face, and neck right now, like we've talked about the last couple weeks, I believe. Exam is on Wednesday, so we still have another day of lecture and lab to finish up. On the first unit, we were able to have our last lab and lecture on a Monday, and then had Wednesday as a day of just studying, some downtime from class, and then the following Monday we had our exam. So this time we have a lot less time to kind of brush up on the newest material, but they were able to give us, I think, enough ahead of time so that we could look it up at least on our own. But we really looked at muscles of mastication and facial expression this week, and then the vasculature and nerves in the face. The pterygopalatine fossa we spent a great deal of time on, so I'm expecting quite a bit of info on that for the exam this week.
Was that the one that somebody posted in our group?
Yeah, that was actually just the facial nerve of the pterygopalatine fossa. So there's quite a bit that we're working on. I think the stress level is a little bit higher because there is the cranial nerves as well, which for some reason is always gets people thinking they may not know them, even though we've gone through them a million times.
Yeah, there's tons of mnemonics to memorize.
Yeah, so that's just one small part of it, and I think we're gonna be fine. I'm not feeling so fine right now, but that's why we have the whole weekend to study. This is why I think we have the program set up really nicely, that we don't have classes on Friday. We cram them into those first 4 days of the week, but then we have independent study where we can just get what we need to brush up on. So I'm looking forward to this weekend to get focused in on anatomy. Now I don't have to worry about so much of the other courses besides our practical and foundations. But looking at those fossas that we haven't talked about previously, it's pretty in-depth anatomy class. The professor said this was the toughest unit of the year, so we're definitely feeling it right now. But looking forward to testing our knowledge on Wednesday and then moving on to the next section. So we'll go into evidence-based practice, which this week was another crazy week in that class because we got cut short. We had a teacher coming in the middle of it, so you can go ahead and tell that fun story there.
So going into evidence-based practice, we actually had kind of a little bit of homework going into that class. So last week we talked about internal versus external validity and the relevance and quality of an article. So like we had to go and we read an article about lateral ankle sprains, and then we were assigned a case study essentially with a female volleyball player who was 15, had a lateral grade 2 ankle sprain, and then we had to read this research article and apply what's the internal validity, what's the external validity, the relevance, and the quality of the article. Would you use it? So we got to do a little bit of our own breakdown of that article, and it was fun. We had some time in class to kind of share our thoughts of how we worked together during that. But before we talk about the class interruption, we did have a little bit of lecture, and it was about the appraisal process of research, and basically like how you stack research against each other, like what is good, what is less good. I guess you wouldn't say, if it's research, it's not necessarily bad. There's value that you can find in some of it, even if it's not great, but it's just less good than what you could have. So you got like systematic reviews at the top, and then well, meta-analysis above that, and then systematic reviews, and then randomly controlled trials. And so I'm going to break down just a few of those things. The randomly controlled trials, it talked about the advantages being allows single variables to be evaluated in defined populations. It provides perspective. You can decrease bias because you have two equal groups and one treatment variable. And then it allows later for that meta-analysis, which is that like ultimate breakdown of everything, of different studies, and then you combine all that information into one meta-analysis. Some of the disadvantages, though, it can be expensive, time-consuming, and not always realistic. It's not always practical. It's not always relatable to the clinic, and it's not always ethical to withhold without treatment. That's why you see a lot of them on like rats or something along those lines, because you can't do some of these things on humans. Then we jumped into cohort versus case control studies, some of the advantages of those. More realistic and able to conduct in clinical practice, so maybe on a smaller scale. You can utilize many levels of control. It's not very lab-like, so you can basically just take like class A is one cohort versus class B is one cohort, and then you can throw in some kind of research mix and see how both the classes come up depending on the variable they implement. Some of the disadvantages to that could be lack of randomization of subjects. It's kind of just convenient sampling. You're not really able to take class A and class B and break them down into the bare bones. You just kind of have to take what you have in those two classes. Usually that per se presides with weakness in the study, and it could be retrospective. So the ultimate bottom line there is it's not always, there's limitations to external validity. So that's just a little breakdown of a couple of the trials. And again, we had kind of our own implementation. We were working through class, and actually one of our professors was filling in for the other professor who I think she was away at a conference or something along those lines. But anyways, we just started in a new classroom, and it was nice because she didn't have to move buildings anymore. So like we're starting in this new classroom, and then halfway through the class, a professor comes in and he's just like, are you guys supposed to be in here?
Yeah.
It was basically like, it wasn't even like, hey, like didn't even go up to the instructor and talk to the instructor. He just like came in the middle of the class and was like, you guys supposed to be in here? Because I got a bunch of kids waiting outside to come into this classroom. And we're like, well, we scheduled it through the university. And he didn't even talk directly to a professor. He just kind of like talked to the class. Clearly there was a professor up front. The overhead projector was on, like we were learning, all the kids were attentive. And this guy was just like, I kind of need this classroom. Can you guys maybe leave? As if we were just in there studying or something.
It was an interesting day. It was interesting.
But it is what it is, and yeah, I mean sometimes that things happen, and just with different classrooms and whatnot. But that was all we had in evidence-based practice. Again, we're just kind of going into the research, breaking it down, and learning how to interpret it. And soon enough, we're going to kind of learn how to write it at the bare bones level too. So I think we're going to roll into kinesiology.
There we go. So lecture this week, new unit. We just had our exam last Wednesday. So we finished up with craniomandibular, I believe, we just had briefly started on it before our test, and so the material had to roll into unit 2. And we're looking at the TMJ. And there at the mandible, we have the elevation, depression, protraction, retraction, and then it can also laterally deviate. So with the rules, we've been doing like convex on concave or concave on convex rules. These apply in this joint as well. Mm-hmm. And with this, the convex aspect is the mandible working on the concave of the skull. So with depression, in this rule, we have a posterior roll with an anterior glide, and then vice versa with the elevation. Protraction, anterior roll, anterior glide. Retraction, posterior roll, posterior glide, because that's kind of like our concave on convex in those parts. And then our lateral shift, which is not a normal one that we've had in the spine or anything like that. We have like a pivot, so if we're gonna rotate to the left, or left shift, if we're gonna left shift, it's gonna be a pivot on that left side, and then the right side's gonna translate anteriorly. So similar to the facets on the spine, where we have one kind of just rotating out here and a glide that way. In a way, I kind of picture it the same in my head.
Yep.
So those were the motions at the TMJ there. With dysfunction at the TMJ, it's usually due to some poor posture, have some tightening of the muscles there, and you'll have like a clicking or some excessive motion. We had some videos that really showed, and they're kind of disgusting, I'm quite honest, just like thinking about it. And then we were all trying to see if we could pop our, we all have like some sort of click or pop with our jaws, it seems like, at the very end range, but nobody dislocated their jaws, so that was good. And then we moved on, so we had the shoulder girdle complex, on Wednesday. We have 3 joints and then a scapulothoracic articulation. So we have the sternoclavicular, acromioclavicular, and the glenohumeral joint. And he made a point that if we have any restriction in any of these joints, that's going to cause some abnormal kinematics throughout. So we have, say I actually injured my AC joint in high school, and so it actually sticks up a little bit. Well, if you look at my sternoclavicular, there's some different motion on that right side now due to, I'm assuming, the injury through it.
Compensation at that joint.
So compensation through it, and that's my throwing arm too. So it was always getting movement, trying to compensate through that movement.
Mm-hmm.
So that was pretty good, clear depiction there for my own personal experience. We talked about the SC joint and how it's a saddle joint. So in different motions, it's going to have different convex on concave rules. So in the elevation and depression, we're going to have elevation and depression is convex on concave, and then for protraction, retraction, it's concave on convex. So the next joint was the AC joint, and a lot of people believe, and it's pretty much a plain joint, but there is a slight concave on convex. There is a little meniscus. Was it the meniscus that's in that joint?
It's some kind of cartilaginous
some sort of
structure,
kind of to soften the articulation there. And then the scapulothoracic articulation, which is mostly just muscles holding it in place. So we have some glenohumeral action with that. So with abduction of the humerus, you actually have 2 different parts moving. You have the glenohumeral and the scapulothoracic motion. And through it, we have 2/3 of that motion through the glenohumeral joint, and then the last third of it is through that scapulothoracic articulation. And it does this so that the stress is kind of distributed over the tissues so that we don't have as much tissue damage through overuse in there. And another unique part to this is the force coupling. So when the humerus is elevated, muscles that have different vectors, so they're pulling in different directions, can make the humerus move in the same, like the 2 different directions are causing the humerus to move in the same direction. So the upper traps fibers are oriented differently than the lower traps, and they're going to pull in different ways, but they're also going to help elevate that humerus.
Same action, different directions.
Same action, different directions. That clears it up. So then we moved into lab with our palpations. We've been looking at the glenohumeral and scapula. So Zach's going to take us on that one.
Yeah, so we finally jumped into the shoulder, and now we're going to work our way down to the arm and the forearm. We've already done some gross anatomical structures of the shoulder, like the traps and like the lats going into the shoulder joint, and then the chest. But now we're going a little bit deeper in the tissue. So we did like supraspinatus, infraspinatus, teres minor, teres major, and then the subscapularis, which is always a fun one to palpate because you got to really get up. I mean, it's literally on the anterior aspect of the scapula, so you got to dig underneath all the tissues and see if you can get a little bit of a feel for it. And you can identify it by finding the tendon on the humerus. So we also identified those tendons and kind of figured out that, a lot of these have the same action, so you have to pretty much find the tendon and do that similar action with a very, very light feel to actually feel that you're on that tendon or that you're identifying that muscle. So that was definitely, it's going to take a little bit of learning and getting used to make sure that you're on the right tissues. Then we started working our way down the arm, onto the biceps, the bicipital groove, the coracobrachialis, and then the triceps. As far as palpation goes, I think that kind of ended it, right? Like,
There wasn't
there
too
wasn't a
many.
whole lot of palpation, just simply because we're doing a biodex project. So we had to break the lab kind of in half and start the introduction to that project, which was pretty cool. The biodex is a machine that you can isolate different muscles or movements on the machine. So for example, we're doing just knee extension, right and left, comparing bilaterally, concentric and eccentric. And then I think we're going to do an isometric contraction also. So we got into the motion analysis lab, which is cool because we haven't actually been in there. We have some pretty nice equipment here. We jumped out of the biodex, kind of gave the breakdown. And what the biodex does is it gives you it can provide forces at different velocities to see what your max output is of your different muscular groups, depending on if you have an injury. So uninvolved, involved, and then you can kind of compare bilaterally with actual printout numbers. So that was pretty cool. I'm actually pretty pumped about that. Going forward, I got to be the test dummy, and my leg was just on fire.
Yeah, it's
I've never had that kind of pure I mean, it's not really pure isolation, but it's about as close to isolation as you could get.
Take out the
Yeah.
trunk, any flexion there. And
Strapped into the
strapped
machine everywhere, and I was back here and just burning all over the place.
I actually had to use that for my rehab at my junior college. I pulled my hamstring and had to test on it initially to see where my hamstring strength was, and then it had to get up to I think 80% of my uninvolved leg strength before I was able to return to play. So I got to test on that about twice a week, and it is exhausting and not so fun whenever you already have an injured tissue for that, because the resistance I think is the same for everything, and you just try to go as hard as you can. So
Yeah.
it's
And especially when you
It's
have an
intense-
injured limb.
Yeah. So it's a very neat tool that we get to use, and we'll likely be using quite often in our clinical
Yeah.
practice as well.
Especially if we're doing any research. So,
Yeah.
anything else to add to lab?
I don't think so.
I actually, I took quiz 2.
Yeah, he went ahead and got to quiz 2 done.
They were walking around and they were asking for anybody that hasn't done quiz 1, and I just was like, I'll do quiz 2 if you're offering it. It kind of threw me for a curveball because it was a structure that we learned prior to the first practical, so I was thinking, I know the practicals are comprehensive, but I thought the quizzes would be kind of segmented into the information that we're learning currently. And I was like, wait a minute, semi-splenitis capitis, where's that?
Yeah, keep you on our toes. I think it's good.
Kind of
though,
want to
'cause,
back up.
I mean, I would personally, if I was just trying to get through with so much info that we have, I would segment it like, I'm done with quiz or test 1, so I'm just gonna focus on test 2 material now. And some of it might go out the window, which they're keeping us accountable, and we have to stay continuously reviewing so that we're not just losing that information. It makes it a little more stressful, I guess. It's definitely better for our learning,
But it's
long-term retention for sure.
Yeah.
So I'm gonna try and get mine done on Thursday. I pray that I don't have it on Tuesday, because I have my practical on Tuesday and then an exam on Wednesday. So we'll see how it goes. I don't think they'll be asking for volunteers again for sure. But I will not be volunteering until Thursday. But all right, so we have clinical science to go through next.
Yep. All right, so in clinical science, we had our exam last week, and this week we started with pain. Introduction to pain. So Josh, what is pain?
So so now I don't only thought of pain as just anything that kind of hurts, just in general, whether it's like tingling or sharp pain or dull pain. I just thought of everything was umbrella, just pain. But we're making it a point right now in PT to segment it based off of the type of pain, and there's different names for each of those. So the original umbrella term for pain, this is quote from my notes in class: unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage.
So
it's perceived.
Exactly.
It's all about perceived.
It's all about perception, which is why, if you punch me in the arm and I'm like, okay, big deal, but then at that same force you punch a much smaller person or somebody who has a different pain perception than me, it might be really painful, because everybody has a different tolerance level, everybody has a different experience with pain, and that's why it's so hard to measure it, like on a scale from 1 to 10, what's your pain. And my go-to is always anytime that I'm talking to somebody and I'm like, oh, does that hurt? How is your pain? I say, what's the most painful experience you've ever had in your life?
Mm-hmm.
All right, on a scale from 1 to that, how painful is this? And I think everybody has their own little ways to kind of measure it, but it's so hard to measure because of the perception. I mean, like Josh just said, and it's an experience associated with actual or potential tissue damage.
Yeah.
You could just threaten somebody with pain and it might be painful.
Right.
The thought of like, oh my gosh, you've hit me before, it's gonna be painful, I feel that pain coursing through my body. So that's kind of the general umbrella term, but there's also a ton of different words to break down those pains. So I'm gonna break a couple of those down for you. Paresthesia, just an abnormal sensation, can be spontaneous or evoked. Diesthesia, unpleasant abnormal sensation, also spontaneous or evoked. So the difference between that one is just it's unpleasant versus just abnormal. So like you might just feel a tingling versus like, oh, that kind of hurts. That tingling kind of hurts. Sensitization, increased responsiveness of neurons to their normal input. So maybe when you touch something, the input that you're touching is more than normal. So it might be a different sensation that it's an increased sensitization of that area. Central pain, which is just increased responsiveness of nociceptive neurons, and I'll break down nociceptive here in a minute. Peripheral, increased responsiveness to threshold, to the periphery, so the peripheral nervous system. Hyperalgesia, I'm still learning how to say these words still.
Yeah, they're not the easiest. I'm reading them right now.
Increased pain from a stimulus that normally provokes pain. And then allodynia, which is pain due to stimulus that does not normally provoke pain. So
he explained in class, it was like a bed sheet is like causing you pain at night, and it's like that's not supposed to happen. That's what like allodynia is. However you say it is.
Allodynia.
We'll learn it.
Yeah.
Promise.
Yeah.
So
as long as I know what it is.
It's different. I didn't realize there were so many different names for pain, or
Yeah.
different types of pain or sensation. So that's pretty cool to learn about, I think. But
yeah, I mean, it's kind of it's a different way of categorizing things instead of saying like, is this painful? Like, no, it's just like it's not painful, but I don't usually feel that tingling when I touch this object, and it's like, all right, maybe you have sensitization, increased sensitization. So it's just a way to kind of categorizing it instead of just saying, oh, that's painful, and then throwing it in that huge pit of perception. So as I mentioned before, you have nociceptive pain, which can be one of three things. You can have visceral, which would be like your internal organs. You might have some kind of nausea or stretch, and like just when you have gastrointestinal distress, you don't usually feel it in one area. It's like, oh, like my stomach is really bloated, or I just feel it all through my stomach or visceral region. Superficial somatic, which would just be like pressure, like you feel that touch, or like temperature, you feel something's warm or cold. And then deep somatic, which can be like inflammation or like dull aches, like you feel like, oh, that's really deep and just kind of achy, not something that you can, again, localize and say, oh, this spot right here aches, but my whole arm just kind of aches. So with that, there's the different fibers that these different inputs travel down. We learned about A delta fibers, which are myelinated and very fast transmission, and then C fibers, which are just unmyelinated and they're very slow. So we had specialized perceptors, which is about 20% of our cutaneous nociceptors, and those consist of those A delta fibers, and they carry sharp and localized nociceptive information to the brain. And again, I didn't mention this at the beginning, where does pain take place? It actually takes place in the brain, because without the connections to the brain, you can't actually perceive that you're in pain. And then there's the polymodal receptors, which are about 80% of your cutaneous receptors, and those are the C fibers, kind of the slow, long-lasting, unmyelinated chains, and they carry dull and poorly localized pain information. So a lot more to learn on that. We kind of just got a little bit of the surface, and our professor was like, if I could teach a whole class on pain, you could teach, probably a degree on pain if you're, that's kind of what neuroscientists and pain specialization kind of work at. And then we were introduced into another thing called gait theory of pain. So the example brought up to this was like if you're pounding a nail and you hit your thumb and you shake it because it's painful, why does that help relieve the pain? And then the other example was baseball. He said, what are you supposed to do in baseball when you get hit by a pitch? And I looked over at Josh because I knew he would know. You're not supposed to touch it.
Yeah, don't rub it.
Don't rub
if
it.
You get hit, don't rub it. You can't show that it looks like it hurts.
Yeah, you gotta be tough.
Yeah,
You gotta
exactly.
be tough. Or if you're Derek Jeter, you don't even get hit and you dance around and act like it was the most painful thing ever just so you can get a base.
Heck yeah, you gotta do that sometime.
Speaking of baseball,
That's strategy.
I was pretty bummed that the Nationals lost last night.
Yeah, it was
So, but
good
I'm
series though.
yeah, it was. But go Astros. I'm a huge Verlander fan, so
There you go.
go Astros. All right, so let's talk a little bit about that gate theory. I'm not going to get too in depth into it because this is way more over our heads than we need to be. But I'm just going to break down some of the main points and kind of the very surface level information that we received. So in the gate theory, you have myelinated afferent fibers that can block unmyelinated C fiber transmission. So what that basically means is if you have two modes of sensation coming in, so again, you pound your thumb, boom, C fibers start transmitting to that information to your spinal cord, which then sends it up to your brain. If you shake it, it gives you sensation all through here, and that's A delta fibers, which are faster transmission. They kind of beat the information to the different gates, and one thing is inhibited and one thing is allowed, and essentially the transmission of pain still gets to your brain, but you receive a lesser
Stimulus.
Yeah, a lesser stimulus. So it's still going to hurt, but it's going to hurt less than if you just slammed your hand or
And
your
just looked
thumb.
at it and just left it alone.
Yeah, so it's kind of just like a way to mitigate a really painful stimulus by implementing a stimulus. And the first thing I thought of was like growing up, my dad would be, I'd be like, I'd slam my hand in a drawer, for example, and I'm like, that really hurt. My dad punched me in the arm. He'd be like, does it still hurt? And I'd be like, well, yeah, but my arm hurts now.
I got two different stimuluses and I have to rub two things. It's like,
Yeah.
oh my gosh.
So that's kind of what I thought about, but it does work.
Actually, it does, yeah.
It does work. So that's kind of the real, very basic definition of gate theory and pain, and I know that's going to be a pretty important part going forward, especially when we're working with patients, and they all have different variations and levels of pain, how to handle that. So yeah, that's kind of what we talked about. We started jumping into immunity, but we got like 2 slides into it, so I'm not even going to talk about it right now. We don't have enough information.
Yeah, more info on it next week. For
Yeah.
Sure.
So let's roll on to the next subject.
Professional topics. So we finished up all of our ethics. We have an ethical paper coming due on Tuesday now because we had some issues with
What accent was that?
What
Was
accent?
that your Missouri accent?
I don't know. Is it coming out right now?
New?
All right, so I'm gonna try and not have an accent. My Missouri accent comes out every now and then. But we moved on to another case study. Now we're using our systems-based practice in an ICF model to tackle the issue.
Mhm.
So we have an older lady who had a right femoral neck fracture. And previous to the fracture, she was pretty active. She's a retired principal, retired like middle school principal, I believe. Very independent, takes care of her husband, who is blind, so she has to take care of him and herself. She doesn't drive, so she relies on her friends to go shopping and whatnot. So after that, she had her fall and broke her leg. She is unable to move. So we had to break it down through each of the areas. So we have health condition, body function, structure, which is like her impairments, the activities that she's limited in, the participation restrictions she has, environmental factors that affect it, and then her personal factors. So we'll just go down the list real quick and go through it because it's kind of good practice for our ICF model when we look at all our case studies. And we did this on both Tuesday and Thursday, so we had pretty good in-depth discussion as a class on it. So with her health condition, she has a right femoral neck fracture. She is also insulin dependent, and she has moderate osteoporosis, which led to the fracture in the fall. Her impairments through the fall, she has now decreased strength, range of motion, balance, and endurance. So the rehab is going to have to take care of all of these areas so that she can get back to full functioning. And prior to this, she used a walker to begin with to get around. So she had some decreased gait to begin with. Then her limitations on her activities, if she has to go upstairs and she's rehabbing this hip, she's gonna have some difficulties. Standing, she's still gonna have to use that walker to get around. And then the participation restrictions, pretty much anything that she has done for her husband is going to be 10 times harder now because she's gonna be using a walker. She's gonna have some balance issues with having to use that to reach and to cook, anything along those lines. Environmental factors, this all has to deal with at home, going to the store, anything where she has to move around. So say she has really thick carpet at home, like really like high carpet, and she has to use a walker or a wheelchair to get around. It's going to be more difficult to roll that walker and to roll her wheelchair to get around. The layout of her kitchen, how conducive is that to her injury? Does she have to move all around the kitchen to get to all the sink, to the stove, to the refrigerator? That's all going to have an effect. Is she going to be able to use the restroom as easily? No, she's going to have to make some adaptations there. And then transportation, she doesn't drive to begin with. She relies on her friends. So what's she going to have to do now with having either a wheelchair to get around, which she's still rehabbing, so she's going to have to use some form of assistance. She may have to use the bus to get to the store. She may have to wait on a specialized bus, and that could make an hour trip into like a half-day long excursion. So these are those factors kind of outside of her. And then ways that she can cope with the injury and the rehab are her personal factors. She was known to be a stubborn individual, so she is going to be pretty determined in what she can and will do. So she was independent beforehand. She was active, doing things. So she's going to try to do that as soon as possible. She was a former school principal, so she can stay composed through all this difficulty. That's going to help her focus on what she needs to do. She's heavy in her faith and likes to meditate a lot, so that's going to help her be positive in going forward in her rehab because she's older, so her recovery is going to take longer. So she's going to need as many positive things to go for as she can to recover fully. So that's what we looked at the past couple days. We'll look more into the ICF model next week and probably have another case study coming up. So that's what we had in our professional topics, a little different than we've had so far, but kind of bringing what we've learned in clinical science, bringing the ICF model into the real world applications.
And we talked about it in foundations too, so.
Well,
The
oh
ICF
yeah, we
model.
did. We did talk about it in foundations as well.
Yeah.
Everything's all interconnected. So on to foundations is our last topic of the day, I believe.
Yep. Let's wrap it up. So foundations of PT exam, we jumped into, so last week we did range of motions through upper and lower extremities. This week we did spine and thoracolumbar range of motions. So we talked about that a little bit in our lecture portion, and then we jumped right into the lab. And the way that you can measure spine range of motion, there's 3 different ways. So we use the cervical range of motion device, the CROM, which is basically this contraption, looks like a dang German death trap or something along those lines.
It's a weird looking deal.
Essentially, it's like a big thing of goggles that you put on with like a little horn that comes over your head, and you have a compass here, a compass over your head, and then a compass, where's the other compass at? Right here on the front?
I think so, yeah.
Yeah,
I think it's
so,
all 3.
yeah, so you can go flexion, extension, side bending both ways, and then rotate both ways, and you can just basically look at the compass after you have it in neutral and zeroed out, and then just take them in any direction. You can also do that with an inclinometer, which we used, and I thought they were incredibly convenient.
Yeah, and I'm using that for my practice for sure.
Absolutely. And you basically just, it's like a little digital dial with like some fluid in it, almost like a balance.
Mhm.
Like if you're using a balance for like a tool bench. You zero it out, you put it on their head, you have them going any way that you want them to go, and it kind of gives you measurement.
And it has, the best thing is it's reliable.
It's reliable, yeah.
So
Yep.
that's huge.
So we did that. That was super easy. And then like thoracolumbar, we used 2 inclinometers. Not as easy because you have to use 2 hands. You have to hold one over the spinous process of the first thoracic vertebrae, and then over the spinous process of the second sacral, the second spinous process of the sacral vertebrae.
So we're like IS level, I think.
Yeah, exactly. So we're like 1 inclinometer's up here and 1's down here, then you have to move through a side bend or a
It's
flexion.
gonna be an interesting one for sure.
It was tough. And then you got to subtract the 2 numbers. So subtract the bottom from the top, and you get your final range of motion. The rotation was a little easier because you just stand over top of them and you use the goniometer, which we're getting better with. So you just have them rotate one way or the other. So that was pretty straightforward and pretty easy. And then we went into like muscle length testing. So the different tests, Ober test, Thomas test, and then some that just don't have names. So we talked about muscle testing and how do you test length of a muscle? Well, you have to take the muscle and do the opposite of what it does in action. So like the bicep, for example, supinates the hand and flexes the elbow. And then it also can help flex the shoulder. So what do you have to do? You have to pronate the hand, extend the elbow, and extend the elbow to make sure you have proper muscle length through the bicep. And you have to do that with all the different muscles. So it's interesting to be able to do some different length testing and see who has deficiencies in that. And it was kind of nice because my partner, she played volleyball, so like she's pretty lower half bound. So I found a lot of like deficiencies in her muscle lengths in her lower half. And me with my football and weightlifting past, I'm very bound through the shoulder. So I had a lot of deficiencies in the upper body muscle length testing. So it's kind of fun to see those different measurables and to see like kind of where we stand.
Mm-hmm.
That's always the fun part.
Yeah,
of this
I
too,
always
like,
see what I need to work on. I really do all these tests.
Yeah, exactly. So that was what we worked on this week, and then obviously everybody's kind of studying for next week for our practicals because we have those coming up. Did we have anything else in there this
No,
week?
that was it. So we're just getting ready for the practical Tuesday and Thursday. So we won't have any more new info, but we'll be wrapping this unit up, and muscle testing isn't on this practical; it's on the next one.
Yep.
So that information will probably go out the window until Thursday. Just being honest, you gotta compartmentalize some things.
Yep.
So anatomy and practical and foundations,
Yeah,
testing more knowledge. Love it.
cool. Well, that's all I have.
That's all I have.
All right.
So,
Let's wrap that up and call that a day. And thanks for checking us out, guys.
see you next week.